Yeah, good evening. So today we'll be learning about diabetic retinopathy. So this is one of the most important topics among the expected optal topics for your NEET and NESET exams. So you'll definitely have a question on diabetic retinopathy. So yeah, let's go into the details. So as all of you know, diabetes is a major concern of healthcare systems, and India, as you know, is called as diabetic capital of the world. So approximately 40% of the population with diabetes will develop diabetic retinopathy. So, and this question, because some particular things that I have highlighted in different colors have already been asked in the previous exams and are expected questions as well. So, uh, yeah. So diabetic macular edema is the commonest cause of visual loss in patients with DR. So this question has been asked multiple times. So that is what is the commonest cause of vision loss in patients with diabetic retinopathy. So I have to answer diabetic macular edema. And also diabetes, as you know, is classified into type 1 and type 2. And it is a disease affecting small blood vessels of the eye, microangiopathy, we call it as. So the risk factors of diabetic retinopathy. So even this question, the questions that have already been asked, I've highlighted them in different colors. So you have to definitely have it on your stick notes, right? So the duration of diabetes is the most important risk factor. So this question also was asked previously in exam, the most important risk factor for development of diabetic retinopathy. So other risk factors are poor diabetic control, pregnancy, hypertension, nephropathy, and other modifiable risk factors like smoking, obesity, hyperlipidemia also are risk factors for development of diabetic retinopathy, both development as well as progression. So the time of screening of diabetic retinopathy is very important. So based on the AO guidelines, and this question has been asked like multiple times. So when do you screen patients with type 1 diabetes? When do you screen patients with type 2? So for patients with type 1 diabetics, your first screening should be done within 5 years of diagnosis of the patient with diabetes, right? And for the patients with type 2 diabetes, you have to screen them immediately. There itself, at the time of diagnosis, you have to do a retinal examination. And if there is no DR detected at that time, you have to follow them up yearly. So please make a note of this because the time of screening is very important. And yeah, in pregnancy, you have to screen twice. Usually even thrice it is done, but yeah, once at conception and then in each trimester and once even postpartum, they usually screen for diabetic retinopathy. Because as I said previously, pregnancy is a risk factor for progression. So in diabetic retinopathy, you have to mainly know three important things, that is pathogenesis, yeah, classification and management. So first thing is pathogenesis of diabetes retinopathy. So you need not know everything in detail. So that's why I have specifically highlighted the things that should be on your stick notes. Okay. So because the pathogenesis itself is a complex, it is a metabolic issue, right? So pathogenesis goes on over time and it is a complex interaction of metabolic disturbances. Due to chronic hyperglycemia, there will be a microangiopathy, there will be chronic inflammation and all the damages that occur in the retina. So earliest histopathological changes you note in diabetic retinopathy are thickening of basement membrane, loss of pericytes, and retinal capillary endothelial dysfunction. These three lines you have to know it at any cost, right? So these are the histopathological changes that you see in DR. Thickening of basement membrane, loss of pericytes, and endothelial cell dysfunction. So this is for your clear understanding. I've mentioned a normal retinal capillary and a diabetic retinopathy. So altered capillary. So normal retinal capillary. Yeah, just a second. Okay, so this cell here, whatever I'm highlighting here, this is a pericyte. Okay, so pericytes are the cells in the capillary walls of retinal capillaries. So this is a normal endothelial cell. So normal blood retinal barrier. You know that inner blood retinal barrier is formed by endothelial cells of capillaries. So this is a basement membrane of the capillary and this is a pericyte cell. So what I have said previously, so there is a loss of pericyte, okay, and there is a thickening of basement membrane, and and there is a loss of endothelial cell function. So all these are shown in this image, right? Yeah. Okay, so this is the entire pathophysiology of diabetic retinopathy. You need not know everything in this, but the ones that I have highlighted, you have to definitely know. So, chronic hyperglycemia, due to which there is formation of advanced glycated end products, due to which there is activation of polyol pathway. You know that sorbitol pathway, we call it as. And the activation occurs through protein kinase C. This was asked once in AIMS exam. So, what is the chemical causing the activation of polyol pathway is protein kinase C. Okay, that leads to oxidative stress and inflammation of the cells and endothelial dysfunction, leading to your increased vascular permeability or leakage. Okay, and protein after the leakage, what occurs is the retinal edema. Also, we call it as macular edema. And due to damage of capillaries, there is extensive retinal ischemia. Okay, and capillaries are damaged and occluded, due to which there is loss of blood supply, and there is hypoxia as a result of ischemia. Hypoxia always triggers the VEGF production, vascular endothelial growth factor. VEGF causes the neovascularization. Neovascularization is the hallmark of proliferative diabetic retinopathy. And these so formed new vessels are fragile and they leak, and thus the disease progresses to advanced stage. So all the highlighted things you can note them down separately, and just like once you understand the topic, I think diabetic retinopathy is very easy for you. The concept is that this is the concept. Okay, so pathogenesis will be clear. And some signs, though there are multiple signs, the signs with the exam purview, these are the signs you have to know from diabetic retinopathy. First one is microaneurysm. So this question is asked more than 4 to 5 times. What is the earliest clinical sign of diabetic retinopathy? You have to mention it as microaneurysm. So microaneurysm is nothing but a saccular outpouching of the capillary walls. So we know that pericytes are absent. There's loss of pericytes. No, from that area of the loss of pericyte, saccular outpouchings occur. That is called as microaneurysm. Location of microaneurysms, they usually occur in the inner nuclear layer. So clinically, we see them as tiny red dots arranged like a cluster of grapes. Okay, so microaneurysms, finally, they end up leaking or they end up undergoing thrombosis. So from the capillary wall, this image which you see, so that is called as a microaneurysm. And this is a clinical image because through fundus examination, this is what we see clinically. This cluster of grapes, the small dot, tiny dot kind structures, these are microaneurysms. These are the earliest sign of diabetic retinopathy in any patients with DR. Okay. And this is a fundus fluorescent angiography image of the same. All the white dots are microaneurysms. Few of them see this microaneurysm which I'm highlighting is leaking. Okay. And this question was asked once. The fully developed ocular picture with microaneurysms is associated with glomerulonephrosis of the kidney. What is it called? This answer is Kimmelstein-Wilson nephropathy. Yeah. So the next clinical sign you should know is retinal hemorrhages. So among hemorrhages, you should just know about superficial and deep hemorrhage. So this image shows both superficial and deep. Superficial hemorrhages, otherwise called as flame-shaped hemorrhages, and they are seen in the nerve fiber layer. Okay, they are due to leak occurring from the larger capillary arterioles. So the one I'm highlighting here is a superficial. And deep hemorrhages, the one I'm highlighting there, in the deeper layers of the retina. There are no deep hemorrhages are called as dot and blot hemorrhages. You see them as a tiny dot blot configuration. So this image on the left is a superficial or flame-shaped hemorrhages in the nerve fiber layer. Sometimes in exam they ask you in which layer of retina you see the following. Okay, superficial flame-shaped hemorrhages in the nerve fiber layer, and these dot and blot hemorrhages in the deeper parts of retina, like inner nuclear layer or outer plexiform layer. Okay, the next clinical sign you have to know is hard exudates. Okay, so as we have already mentioned, microaneurysms will leak. So when microaneurysms will leak, so the blood and vascular contents also will leak into surrounding tissues, causing retinal edema, right? So the leaked vascular tissue macrophages come and engulf them. So these lipid-laden macrophages are nothing but called as hard exudates. You see them as tiny yellow spots. They are also seen in the inner layers of retina, that is in the outer plexiform or inner nuclear layer. So hard exudates are nothing but waxy yellow lesions with distinct margins. You have to know the thing called distinct margins because there's another soft exudate which doesn't have a distinct margin. So this clinical image shows hard exudates. Image on the left shows multiple hard exudates and microaneurysms. Image on the right is more extensive hard exudates in a succinate pattern. There's something called a succinate retinopathy. If you get a ring of hard exudates like this, it is called a succinate retinopathy. Okay. So next is soft exudates. So I've mentioned hard exudates previously with distinct margins. So the exudates without like with indistinct borders is known as soft exudates. But soft exudates are not lipid-laden macrophages. Soft exudates are ischemic disruption of nerve axons. You know, nerve fiber layer of retina contains nerve axons, right? So due to ischemia, there is disruption of the nerve axons, and these neuronal debris which accumulate in the nerve fiber layer are known as cotton wool spots or soft exudates. So cotton wool spots appear as a fluffy whitish superficial lesions. And cotton wool spot is clinically very important because cotton wool spots indicate ischemia. So more cotton wool spots means more ischemia and retina is progressing. The disease is progressing to advanced stages. So these are cotton wool spots or soft exudates, this whitish fluffy things. Okay. So this thing called as IRMA, intraretinal microvascular abnormalities. So this entire thing of pathogenesis is roaming around retinal ischemia, right? So when an area in the body is ischemic, what does body do? So body attempts to re-establish a blood supply. So by opening up shunt vessels, even anywhere else in the body, the same mechanism. So right. So these shunt vessels which open up between arterioles and venules are known as IRMA or intraretinal microvascular abnormalities. Okay. So IRMA also they clinically appear as intraretinal lines without crossing major blood vessels. So this image shows you details of IRMA. So they are shunt vessels. So this particular thing is called IRMA, usually seen in the ischemic areas of retina. And clinically they appear as fine red lacy network of vessels. So, and venous changes. Coming to venous changes, venous abnormalities are also seen in diabetic retinopathy. So, the most commonly seen ones are dilatation and tortuosity. All of them you can see in the image to your right. So, dilatation and tortuosity, looping, beading, and sausage-like segmentation. All these are the venous changes observed. Okay, so looping of the blood vessel, looping on your left, and the venous beading in the center, and sausage-like segmentation to the right. Other venous changes seen in diabetic retinopathy. So these are the clinical signs that you should know for the exam. Okay. So pathogenesis is over, clinical science is over. Classification, which is very important, and you will be already knowing about the classification from UG, right? So clinical classification or ETDRS. So what is ETDRS? ETDRS is early treatment diabetic retinopathy study. So they have classified the disease as non-proliferative and proliferative diabetic retinopathy, NPDR and PDR. So this classification is like very important based on clinical science, and for management purpose they have classified. Okay. And descriptive classification is also used. So for us to understand better, there's descriptive classification as well. Background diabetic retinopathy, maculopathy, and advanced disease. So diabetic maculopathy is important among descriptive classification. Okay. So I have simplified the classification of NPDR as much as possible. This is a most simplified table you can find, because on books, if you see on the standard reference books, there's a very big table of classification of NPDR. So this is all you need to know. For the exam, you need to know only this much for classification of NPDR. So the categories are no retinopathy, very mild NPDR, moderate NPDR, severe, and very severe. So each category, there are some key points. If you know that, you will be able to classify easily. No retinopathy, there is no, so definition, if you see no DR, okay. Very mild NPDR means only microaneurysm is present. As already mentioned, microaneurysm is the earliest sign of diabetic retinopathy, right? And mild NPDR means along with microaneurysm, if you see a hard exudate or retinal hemorrhage, you classify it as mild NPDR. Okay, but there is no IRMA and no venous bleeding. So you have to know that until there is occurrence of IRMA, it is always a mild NPDR. Once you see IRMA, once you see a mild IRMA, okay, IRMA means shunt vessels or venous bleeding, you classify it as moderate NPDR. So moderate, along with the above signs, plus you have to see mild IRMA and venous bleeding. So severe NPDR is a 4-to-1 rule. You have to know the 4-to-1 rule. It is asked multiple times in the exam. 4-to-1 rule is having one or more of either severe hemorrhages in all 4 quadrants, so that is 4, and significant venous bleeding in 2 or more quadrants, or moderate IRMA changes in 1 or more quadrants. So having any one or more of these 3 categorizes the patient into severe NPDR. And very severe NPDR is nothing but having 2 or more of the 4-to-1 rule. So that's it on classification. And classification of PDR, if you see, the previous one, NPDR has many categories. PDR, it is nothing. Either it is mild to moderate or high risk. Mild to moderate is, so PDR means new vessels, neovascularization, right? So neovascularization is present, but not to the extent of meeting the high risk criteria is mild to moderate PDR. And high risk PDR means neovascularization is present. There are 3 high risk categories of PDR. So NVD is neovascularization at the disc, more than 1/3 of disc area, or any NVD with vitreous hemorrhage, that is any size of NVD with vitreous hemorrhage, or neovascularization elsewhere, the size of which is more than half the size of disc area with associated vitreous hemorrhage. So these are the high risk categories of PDR. You have to definitely, revise these, because high risk PDR the 3 points will be asked as an MCQ. Okay, and complications of PDR you have to know. I think you already know this complications. So what are the complications of new vessels? They'll bleed or they'll lead to retinal detachment, right? So persistent vitreous hemorrhage, fractional retinal detachment, or neovascular glaucoma are the complications of PDR. So just a description on PDR, proliferative diabetic retinopathy. So before the new vessel develop, at least 1/4 of the retina must be perfused, must be non-perfused. Okay. And about 2/3 of type 1 diabetic patients will develop PDR over 30 years. And all the lines mentioned in red are previously asked questions and are also important points. So why PDR occurs, we already know, right? Ischemia leading to hypoxia, leading to VEGF formation. VEGF will cause neovascularization. So NVD or new vessels at the disc means new vessels on or within 1 disc diameter from the optic nerve head. And NVE or neovascularization elsewhere means, so it is elsewhere away from the disc, elsewhere in the retina. Okay, so neovascularization is always associated with fibrovascular tissue, means associated with fibrosis. This fibrosis may either lie flat on the retina or it can attach to the posterior vitreous face. Okay, so if it is attached to the posterior vitreous face, the fibrovascular tissue will lead to traction, will lead to tractional retinal detachment, and while traction, there will be tearing of blood vessels. All these new fragile leaky vessels, they tear. And this is the commonest cause of vitreous hemorrhage. So this question is asked previously. The commonest cause of spontaneous vitreous hemorrhage in adults with diabetic retinopathy is due to tearing of blood vessels. And also this is the commonest cause of visual loss in PDR. So the 2 questions you should remember, if the question is like what is the commonest cause of visual loss in patients with diabetic retinopathy, you have to answer it as diabetic macular edema. But if they ask the commonest cause of visual loss in patients with PDR specifically, you have to give vitreous hemorrhage as your answer. Okay. So NVD, NVE, and in some patients, NVI also develop. NVI means new vessels on the iris. It is known as rubeosis iridis. So this causes neovascular glaucoma. And commonest cause of rubeosis iridis is also diabetic retinopathy. Okay, this image for your clear understanding. So this is the new NVD, neovascularization on the disc, and FFA image of the same. And the picture in the middle is NVE, that is neovascularization elsewhere, and the rightmost picture is NVI, that is on the iris. Okay. So you have to know a bit on diabetic maculopathy. So as I already mentioned again and again, diabetic maculopathy or diabetic macular edema is the commonest cause of visual loss in patients with diabetic retinopathy. So why the maculopathy occurs? Either due to edema, exudates or ischemia. Edema, as you know, the dilated capillaries, dilated veins and everything, they leak. They leak into the retina and the fluid accumulates first. Initially, fluid accumulates in the watershed zone, we call it as, between outer plexiform and inner retinal layers, but eventually entire thickness gets involved. So diabetic maculopathy are again three types: focal, diffuse, and ischemic. Focal, as you know, in a well circumscribed area, and treatment is also with focal laser. Diffuse is diffuse retinal thickening. You can treat it with macular grid laser. And ischemic maculopathy. So due to ischemic changes, macula will look relatively normal clinically, okay? But FFA will show capillary non-perfusion and enlargement of foveal avascular zone. So there is no use of laser in ischemic maculopathy. All right. So image on the left for your understanding, it is a focal maculopathy because it is well circumscribed. And this is a diffuse maculopathy with the arrows are mentioned. This area of diffuse maculopathy, we cannot see it properly clinically, but FFA shows it clearly. So among maculopathy, the most commonly asked question is CSME. So what is clinically significant macular edema? You have to know these three criteria of CSME. So if these three are present, you can classify the patient as having CSME. Okay. So any retinal thickening or edema within within 500 microns from the macula center. So the image below I'm highlighting there. So any retinal thickening within 500 microns from the macula center, or any hard exudates, the yellow ones here in the image, within 500 microns from the macular center with retinal thickening, or any retinal thickening of one disc area or larger, a part of which is within one disc diameter from the macular center. So if a patient falls into having all these three features, we can put him under clinically significant macular edema. So because CSME has to be treated immediately, so it is classified separately. So CSME, as you know, it is best detected on clinical examination because patient may or may not have symptoms. You have to do a slit lamp biomicroscopy, and the loss of foveal reflex and thickening around macula will show the CSME. So final part is management of diabetic retinopathy. The general steps of management is like same for all the lifestyle disorders. So firstly, diabetes should be under control, right? So you have to do a complete ophthalmic history examination in detail to gonioscopy, tonometry, detailed fundus examination with indirect ophthalmoscopy should be done. And lab investigations, the diabetes workup, lipid profile, everything. And among investigations, the most important one is fundus fluorescent angiography. I've put the images before, right? So it is the most important because it shows us areas of ischemia, areas of non-perfusion, areas of leaking microaneurysms. Anything that we can't see clinically, we can see in FFA. So fundus fluorescent angiography is a very important investigation in diabetic retinopathy. So another one is OCT. OCT will show the areas of retinal thickness and fluid accumulation. Okay. And cystoid macular edema, that is fluid at the macular area, appear as flower petal pattern on OCT. Okay. And B scan for advanced disease, if patient is having RD, vitreous hemorrhage, you can see on B scan. So general lines of management, you have to go for medical consultation for strict diabetes control, and other modifiable diseases should be kept in mind, should be kept in control. Smoking, patient has to stop smoking, obesity control, etc. For diabetic retinopathy treatment per se, apart from the general tight glycemic control will always be there, okay? And other modifiable risk factors should always be met. Apart from that, so the main, if we come to treatment part, from this table, this is a very simplified table for management. So in all stages of NPDR, there is no treatment if you observe, okay? Mild NPDR, review in 12 months, okay? Mild NPDR 6 to 12 months, moderate NPDR, review in 4 to 6 months. Severe and very severe NPDR, you know the categorization, right? Because they are very high prone to going to PDR. Up to 50% of patients will go to PDR, okay? So you have to screen them within 3 months. Screen once again within 3 months. Okay, so the immediate treatment is only necessitated in PDR and diabetic maculopathy. Proliferative diabetic retinopathy, you have to do a PRP, that is pan-retinal photocoagulation, as soon as possible. And in patients of diabetic maculopathy, we discussed in the previous slide, there's diffuse maculopathy, focal, and CSME, right? So for diffuse maculopathy, you can use a diffuse macular grid laser. For focal maculopathy, focal laser. And for CSME, clinically significant macular edema, for center involving cases, you will use anti-VEGF injections. And for non-center involving, again, laser can be used. Now, the entire treatment of diabetic maculopathy, anti-VEGFs are like on the trend, and the lasers are being taken up by anti-VEGF actually. Yeah. So advanced diabetic eye disease, as that is the last stage of DR, which contains vitreous hemorrhage and tractional RD. Vitreoretinal surgery is the only option. There is no other treatment possible. Okay. So CSME not involving the center and CSME involving the center, you have to know. CSME not involving the center of the macula, you can treat it with focal or grid laser photocoagulation. So they've asked this question multiple times. So what is a grid laser photocoagulation and focal laser photocoagulation? And the lasers used are argon laser, diode laser, or frequency double Dendiag lasers. Okay, and if you cannot see the areas clinically, you can take the help of fluorescent angiography and identify the areas of leaking microaneurysms. And the spot size they usually ask. So 50 to 100 micron spot size is used to create light intensity burns in a grid pattern. Okay, and you have to always avoid the fovea and foveal avascular zone. And CSME involving the center. So if fovea, subfoveal layer is involved, you cannot throw a laser light to the fovea. So that is called a center involving clinically significant macular edema. You have to treat with intravitreal anti-VEGF injections. So the names of anti-VEGF injections you have to know. They'll ask you. So aflibercept, bevacizumab, ranibizumab. Sometimes even the famous trade names are asked. Aflibercept is called as Eylea. Bevacizumab commonly called Avastin, and ranibizumab is called as Lucentis. This image shows you the grid laser, macular grid laser. See, the center foveal avascular zone is avoided, and the C-shaped grid of laser points are put around the macula. So this is for maculopathy, treatment of maculopathy, laser treatment. Okay, and you have to know a bit on PRP. So PRP is the only mainstay of treatment for proliferative diabetic retinopathy, right? So what is pan-retinal photocoagulation? Entire retina will be photocoagulated, okay? Because retina is ischemic. On photocoagulation, what will happen? The hypoxic retina will be converted into anoxic retina. Hypoxia, because hypoxia triggers the formation of VEGF. So if there is no hypoxia, there is no formation of VEGF, right? So when hypoxia is converted into anoxia, there is reduced metabolic demand. So there won't be any release of VEGF. So that will stop further development of PDR disease. Okay. Procedure of PRP, in this only few important things you should know. PRP is usually done using a contact lens. Okay, contact lens to get a magnified fundus view and also stability. A pan-fundoscopic lens is preferred. And again, argon frequency double Dendiag and diode lasers are used. And spot size, for the focal macular laser, I told you 50 to 100 micron is the spot size. But in PRP, it is a bigger spot size. It is 400 to 500 micron, few books says, but you can remember it as 400 micron. And each spot is separated with each other with one burn width apart, okay? And the intensity is to blanch RP. And area of treatment, it is always treated outside the area of temporal vascular arcades. Temporal vascular arcades, and also an area of 2 disc diameters is left untreated nasal to the disc. And a total of 2000 to 4000 burns are required for the entire treatment. So the treatment takes 2 to 4 sessions to complete. Doesn't complete in one session. Okay. So these images are for PDR. So this is a pan-fundoscopic contact lens being used. And you can see the laser spots, right? All the laser spots are thrown. They are extended anteriorly up to the equator. And all the laser spots are outside the macular arcades. These are known as vascular arcades. So the entire laser spots are outside the arcades. So this image, so this is a total image showing entire thing extended anteriorly. till the equator, laser spots will be put. And this is I think a month. This image shows a patient 4 weeks after PRP. So the entire area is blanched and it is an anoxic retina now. So there is no metabolic demand and no release for VEGF. Okay. So finally, advanced diabetic
Doctor,
eye
sorry,
disease.
sorry to interrupt. We have less than 7 minutes, so you can.
Yeah, done. Yeah,
After
2 more
that,
slides, right?
yes. Okay.
Yeah. So advanced diabetic eye disease. So the main things in this you have to know is vitreous hemorrhage and fractional RD. So because I have included this because this question has been asked once, what is the indication of vitrectomy in advanced eye disease? So the following are the indications of vitrectomy. Severe persistent vitreous hemorrhage. So for which precludes adequate PRP is the most common indication and followed by fractional RD is the second most common indication. So these mentioned below the third posterior hyaloid phase combined RRD and TRD, that is rhegmatogenous and tractional, and anterior segment neovascularization. These are the indications of vitrectomy. And this image shows the features of advanced diabetic eye disease. You can see persistent vitreous hemorrhage. You can see the tractional retinal detachment. All right. Yeah. So that's all our diabetic retinopathy you have to know from the exam point of view. I've included a few MCQs. I think you'll be able to answer this because all the MCQs which have been asked on DR is already covered in the presentation. Yeah. So first question, it was asked in AIMS November exam. In diabetic retinopathy, the earliest clinical sign is, we've discussed multiple times, it's microaneurysms. Okay. And all of the following are findings in diabetic retinopathy except. So arteriolar dilatation. So this point was not there in DR. Rest everything we have already discussed. So causative factor for macular disease. So diabetic maculopathy in diabetic retinopathy. Why does it occur? So ischemia is a factor, neovascularization, oxidative stress, all these are there, but disruption of RPE is not in DR. Okay. So soft exudates are seen in which layer? So what is soft exudate? Soft exudate is cotton wool spot. Cotton wool spot, as you know, seen in nerve fiber layer. So most common cause of rubeosis iridis. So I've already mentioned it is diabetic retinopathy. And the last question, it was asked recently in the recent NEET PG exam. It is a clinical question. So a 70-year-old patient with type 2 diabetes underwent a macular grid laser for mild NPDR with CSME. Okay. And 2 months later, she shows features of vitreomacular traction. What is the management? So tractional component came means this patient went to advanced diabetic eye disease. So advanced disease treatment is vitrectomy, as mentioned, vitreoretinal surgery. So option C, pars plana vitrectomy is the answer. Yeah, so thank you.